Provision of out-of-hours care is considered a key priority internationally. However, little is known about the role and contribution of healthcare assistants in the provision of such care. Dr. Felicity Hasson, Senior Lecturer with the Institute of Nursing Research in Ulster University and PCRN member, and Professor Sheila Payne from the International Observatory on End-of-Life Care at Lancaster University and AIIHPC expert collaborator, will present findings from a 4-phase mixed methods study exploring the role and contribution of the healthcare assistant in out-of-hours community palliative care provision across the UK. So over to you, Felicity and Sheila.
Thank you so much. Emer, can we just start? Lovely. Thank you so much. So welcome everybody, and thank you so much, Karen, and thank you for being here today. And it's lovely seeing so many familiar faces and names on the participants list, so that's great. So what I'm doing today is I'm going to outline a very brief synopsis of some of the research findings that was undertaken by from a large-scale study funded by Marie Curie. And it looked at the role of the healthcare assistant in the out-of-hour adult community palliative care. So before we go into the study, I really want just to take a step back and think about, well, what do we mean by out of hours? So there's no standard definition of what out of hours refers to. Internationally, within countries, across clinical settings, and across service providers. But in the UK, it genuinely refers to the period between 6:30 in the evening to 8 a.m. in the morning. And that covers weekdays, weekends, and public holidays. Okay, but that's very variable. For the patient, it actually represents a substantial amount of time, 63%, where there is no in-hour services. And unsurprisingly, that's a research priority. Now, there's been a rise in demand across the UK and Ireland with regards to delivering of palliative and end-of-life care in the community. And why? Well, there's a number of reasons, and I think we all know this. It's about our aging population. We have more chronic life-limiting conditions being diagnosed. And we also are in still the ripple effect of COVID, where we've got late diagnosis happening. Now, King's College London just identified quite recently that there's actually been a trend of more deaths occurring in the community than in hospital. And they predict this is actually going to increase. But whenever we think about the services we provide, and you think about the demand that's going to happen in the community, we have to think about who provides those services. And we really have the generalist and the specialist who are providing those services. The generalist is really the GP and the district nurse. And the district nurse is key in that service provider provision, because they actually represent 40% of their time is spent on delivering care to palliative and end-of-life patients. However, the district nurse's role is actually decreasing in that they're not entering into that job. So there's high attrition rates, there's high levels retiring, so there's issues in the delivery of that generalist service going forward in the community. Whenever we think of specialist providers, well, most of our specialist providers are hospice-based. They're dependent on charities. They're dependent on funding. So the resources are limited into what they can actually provide. So what does that mean then? Where's the care assistant here? So where's the care assistant? So this was my question. Where's the care assistant in all of this? So internationally, there is an increasing trend, regardless of clinical setting, regardless if it's palliative, end-of-life care, acute, social services, we are relying more on the assistant role. Now, the assistant role can be identified back from Florence Nightingale's time. Yet even today, we have no standard definition of their title, their scope of practice. We have no agreement on how they're prepared. And we have no agreement with regards to the regulation. Some countries have regulation, semi-regulated, or no regulation whatsoever. Now, I'm aware in Ireland, they have the FETAC program for care assistants, but palliative care is a voluntary option. So there's no definite general education program for the care assistants. What we do know from the evidence in community in our palliative care provision, that they do play a fundamental role. But that left me wondering, what's their role in out of hours? And so with the help of Marie Curie, who funded the project, we undertook a large-scale project to investigate, well, what do they do? What do they do and what's their contribution and do they have any impact? As Karen alluded to, this is across 4 phases, and I'm going to very briefly outline each of these phases and each of the findings of these phases. So the team undertook an international scoping review, and that was really to find what evidence is out there on what do they do, and if there was any policy out there to guide their scope of practice, and anything with regards to their impact. We searched a range of empirical and grey literature. We aligned it to methodological guidelines. We actually had over 2,800 hits, but from that, 6 only related to the role of the healthcare assistant in the out-of-hour period. So let me very briefly outline some of the findings from that scoping review. Well, obviously, with only 6 papers, there's a dearth of evidence. We really don't know what's happening and how the healthcare assistant in the out-of-hour period is actually being utilised. From those 6 papers, 3 were from Canada and 3 were from the UK. And all of them were very small scale, based on qualitative, very subjective findings. What we found was, from the analysis of those 6 papers, that the role was centred on the patient and supporting the family. It was about that support that they gave. But interestingly, particularly from Canada, what they identified was the care assistant was there more than the registered professional. They knew the patient. But all the papers, the 6 papers, said there's an actual challenges with this role. We don't know if they're training, if they've been trained. We don't know if their training matches patient need. Care assistants were having to deal with highly intensive and emotional situations. And many times they were being asked or they engaged in tasks way beyond their remit. There was no policy identified from this review that referred to the role of the healthcare assistant in the out-of-hour period. So there's still huge gaps in our thinking and how we understand how they're being used. So that led us to engage in our phase 2. And phase 2 was to engage in a national online census of UK adult hospices across. And we devised a questionnaire and we sent it to all managers of the adult out-of-hour services to complete. We had 57%, 81 respondents. Now, I have to say this survey was definitely undertaken in the COVID era, the COVID time period. And so that needs to be considered. And because of that, we actually included 15 questions specifically on the impact of COVID on the delivery of out-of-hour services. But what did we find? With regards to the services, you can see that the main service they provided was a telephone. The telephone was the key out-of-hour service that was provided to patients and caregivers and health professionals. Now, hospices, some hospices provided no out-of-hour services. It wasn't within their remit. Other hospices provided just a telephone. Other hospices provided a multiple of out-of-hour services to complement one another. So, for example, telephone, care at home, for example, hospice at home, and rapid response services that all were there to facilitate the support of keeping the patient at home and to die at home. Now, across these services, there was widespread variation with regards to how you accessed them, who accessed them, how they were staffed, and how they were resourced. But across every one of these services was a care assistant. From telephone, care at home, and in the rapid response teams. So the care assistant was a consistent feature right across. However, when we asked about the care assistant, there was huge variation with regards to their pay scales, the training that they were provided. But there was similarities in what they thought care assistants were doing. They thought they were monitoring symptoms. They were providing the support, particularly emotional support, to the carer and the patient. and liaising with other health professionals. So that's what the management believed the care assistants were doing. Now, because, as I said, this questionnaire was delivered during COVID, we asked about the questions about the impact of COVID. And if we reflect back, we all know services changed. We changed our practice. Services were completely refigured. Hospices either stopped completely delivering out of our services and in the home services because of the risk of infection, and carers did not want them to be present either because they were terrified of the consequence to their family member. But it also changed in that services then shifted from being delivering care in the person's home to telephone only. And they had to do that, and they had to use their staff and their resources more effectively. Other hospice providers linked in with other hospices to share resources. So it really had a massive impact to how it impacted the patient and the family care at home. But what does this mean? What is it? We're only getting one insight into what the care assistant actually does. So then we built on that, and we undertook a number of organizational case studies. And the case studies were based on hospices that took part in phase 2. And we had 6 case studies. We had multi-visiting. Now, multi-visiting is referring to where there's shorter episodes of care within a nursing shift. There's multiple episodes of short care in the nursing shift. Planned variable is where it's in advance. There is overnight stays planned in advance for that caregiver. Hospice at home is where the delivery of care is delivered in the person's home, and delivery and palliative care is delivered there. And that's mainly led by care assistants. Rapid response is where you have the specialist. So a specialist nurse may or may not be paired with a care assistant to go in and deal with crisis situations. So it's just what we said, they're rapidly responding to the situation. But they would then disengage and leave once that crisis situation has been resolved, and leave that then for the patient, family, or the hospice at home team then to deal with the remainder of the care. So we use case studies and we use multiple methods. So every one of, I should say, of those cases had a care assistant involved. And you will note there was no telephone involved there. So that's a gap in our understanding. There was no telephone service there. So from these case studies, we looked at different methods. We approached different methods. We looked at secondary data, and that was anything to do with the out of our service, anything to do with the care assistant. So we looked at anything, so job descriptions, policies, training, everything about that, the delivery, the criteria of how you access out of hours, to the whole procedure of the average length of time it occurred. And we also undertook a number of interviews from carers, both active and bereaved, managers, specialist staff, and healthcare assistants, anybody associated with that out of hour delivery. And in total, we undertook 59 interviews. Now, you'll note that we're missing a really important voice. We're missing the voice of the patient. And whilst we tried to get patients to be involved, what happened was, and again, this was COVID, there was so many late referrals. Patients were entering into the care of the hospice at a very late stage, where they were physically and psychologically unable to take part. And there was a rapid decline in their health. So we are missing their voice. But let me just provide you then with a little of an insight. It's going to go, yep, into the characteristics of each of the sites. So actually you can see we had 4 sites from Northern Ireland, 1 from England and 1 from Wales. All the multi-visit, the plan, the rapid, and 3 hospice at home. The actual hospices varied in the number of beds they had and the other services they provided. But you can see the breakdown of participants across each site. But let's look at the findings of the case studies. Across the board, everyone recognised the need for the out-of-hour care. However, they said it was complex. It was complex to deliver it because There wasn't the resources. There wasn't the access to medication as easy as it should be whenever you're in the end period. There wasn't access to those other staff that you could bounce ideas off and get their advice from or make a referral really quickly. It was complex, and all participants, carers as well, recognised the need for all types of services, acute, community and social services, to work as one. However, they also recognised the increase in demand was there and that this needed to be more streamlined in order to ensure the effective delivery of care. Everyone spoke about the unpredictability, or as they referred, the unknown. I work on my feet, I think on my feet, was repeatedly in every interview schedule. Managers were aware they were sending staff out to unpredictable environments, whether it be specialist or care assistants. They were going into an environment they didn't know. They were going into a family situation they didn't know. And they were going into a family and patient whose status could change in the turn of a drip. So the unpredictability was a huge concern for every staff member, and how they approached it and how they managed it. Now, there was a huge difference identified between the care assistant and the specialist staff. The care assistant was there. The specialist staff was dipping in and out. So they did not have that ability to get to know the patient, to get to know the family. And they were going into the family's territory. And that was repeatedly said. They just didn't know what they were facing. Many times, staff, particularly care assistants, were lone workers. So they were going in without any staff near them. They may have had a mobile, all of them had mobile phones with them, and they would check in the morning, check in the evening, but they were on their own, essentially, and only calling for assistance if and when required. And they were dealing with unpredictability. And they now had to navigate that in order to deliver care and to keep them safe. Whenever we asked about the role of the care assistant, this was complex. Overarching, the healthcare assistants were identified as having greater insight into the patient and the carer's needs, more so than registered staff, because they had the time. They had the time to build relationships. They had the time to build rapport. And they got to know, they got to understand the family dynamics. They got to be able to read the patient's verbal and non-verbal cues. Care assistants were key to supporting the care. And there was narratives told where once the care assistant settled the patient, the carer would go to sleep, maybe 4 or 5 hours, but then the carer would wake up. And the carer would deliberately wake up to engage in a conversation with the care assistant. In the early hours, they would have the conversation about them, about their fears, about the questions they didn't want to ask whenever the patient was awake. And they didn't want to ask professionals because they knew professionals, the registered staff, were so busy. They were coming in and out. But they could have a conversation in their home environment, a safe environment, with someone who they connected with. And that was teaching them not only about death, but also about dying and what happens afterwards, the bereavement period. And it focused on them. And they said, the carers indicated that they valued that more than anything. That helped them emotionally and mentally in that role. Now, care assistants in this study undertook a range of tasks, not only from personal hygiene to the many activities of daily living, the washing, the dressing, the toileting, etc. But they also monitored syringe drivers. They took down syringe drivers. They were monitoring everything, all the equipment going on around the bed. They engaged in the last offices, the care of the dying person, but the death period. They ensured that the family's wishes and the patient's wishes were upheld. Whether that be they placed a jersey that was sentimental that the patient asked on them once they passed, or they placed the picture of their wedding day at the bed. They ensured that was actually enacted. But across that period, care assistants thought on their feet. They continually, before they went in, they monitored the environment. Whenever they went in, they assessed the family, they assessed the patient, and they continually assessed the patient, not using any assessment tools, but just by observation, gauging the patient's verbal and non-verbal cues. Are they deteriorating? Is there a physical or emotional decline? The care assistant was then left with the responsibility of making a decision, making a call. Now, I should note, the majority of these care assistants had no formal education. They were experienced, as I say, hands-on carers, and they had the intuition and the experience to read situations and know what to do. Now, that didn't mean it was all smooth sailing. There was many times they were left in complex situations to make complex clinical decisions of when to make a call. Caregivers in the UK at present, and I know this may change, do not administrate medication. Therefore, whenever a patient declined and they tried to reposition, they tried to manage the situation themselves, if that didn't work, they then had to wake exhausted family members to administer the medication because they weren't allowed to. Healthcare assistants then had to deal with that, the anxiety of the carer thinking, oh, this is it, this is it. John's going to pass. This is the time. They dealt with that. Now, if the medication that the carer administered didn't work, it was the care assistant who then had to make the call. Do I phone? Who do I phone? And will they arrive in time? There was many stories where care assistants said, we were unclear, but we just did it. Or I knew he wasn't right. I knew the pain medication that his wife gave him wasn't working. So I called rapid response. But whenever they were waiting on rapid response to come, they had to deal with a patient who was obviously responding and deteriorating, and the anxiety of a family member who at that stage for many had called additional family members thinking this was it. This was the time to say goodbye. So there was huge trauma and emotional challenges that a care assistant had to deal with. And that delay, sometimes between 1 to 4 hours, a care assistant had to deal with that. They were left managing the complexity of that situation. Now, whenever the rapid response team, for example, arrived, they came in and they dealt with the patient. The carer then dealt with the family. But that was very difficult for carers as well, because they were in a situation where they felt powerless. They couldn't do the job that they wanted to do. They couldn't help the patient because there was a delay. But they then had to renegotiate that relationship again, reassure the caregiver and the families, and get it back on an even keel again. And then go back and care for the patient, whilst the rapid response team then left. So there's huge dilemmas that we're placing and to engage in complex decision-making that are placed on the shoulders of care assistants, many lone worker care assistants. So what's the impact? Without a doubt, every carer in the study identified that it enabled them to cope. It allowed, many carers refer to the fact they were on their knees. They were on their knees by the time out of our services were provided to them. And they were exhausted. It actually facilitated them to care and continue caring in the home. And as a consequence of that, it also then enabled them to continue to allow the patient to remain and to die at home and fulfill his or her wishes. Now, from the staff's point of view, they recognize that as well. But they said they do more. They do a lot more. They're our eyes and ears. That was used many years ago. They're the eyes and ears of the ward. Well, they're the eyes and ears in the community, and particularly in the out of hour period. They tell us, they do a handover to me before I go in as a nurse. And I am told, this is the situation with this family. This is the situation with this family's dynamics. Here's an update on the patient status. And it might be to the very trivial. Actually, they've got a Rottweiler there, so be careful. It could be something like that. To actually, we've tried this, it doesn't work. You need to, I want to pass over to you. What managers and staff recognised was that care assistants allowed them to concentrate on complex cases. It allowed them to really be specialists and deliver that crisis care when and if it was needed. So what did we do with this? So our phase 4 and our final phase of the study. We thought, well, what do we do? So what? You know, what does it all mean? Is it just going to go in a paper and happy days, that's it? That's not what we wanted to do. So we ran a number of deliberative workshops with key stakeholders, with care assistants, managers, staff, and carers from Carers NI. And we asked them to talk about their experience of healthcare assistants and the out of hour period and their care and their experience of managing that. And also to think about, well, what's the key findings from this study? Because there's no point coming from me. You're living it. What's the recommendations you would like to take forward? I'm just going to very briefly outline the 3 top recommendations. The first one was, come on, folks, recognise the role. The role of the healthcare assistant has to be acknowledged. Its profile has to be recognised. The second one was, hold on a minute, there's no point just recognising this care assistant role in out of hours. It happens within and across all palliative and end-of-life care services. And it should be valued. Now, what our respondent said was, talk is great, but let's have a wee bit of action. The action is you need to invest in this worker. You need to educate them. You need to deliver them a career pathway because they don't have it. And you need to pay them. I don't think there's a big shock whenever you think logically. So we ask carers, care assistants, managers, and staff who work in out of hours and palliative care. They all said, this is an important role. It needs to be recognised, and we're not doing it. Now, ladies and gentlemen, I did say this was going to be a brief synopsis because there's so much data in this study, but it would be very remiss of me not to say thank you to the carers, the staff, and all the service managers and the gatekeepers who allowed the study to take part. And obviously to Marie Curie for funding this. And on a personal note, I'd also like to thank the research team, like Sonia McAfatrick, Tracy McConnell, Sheila Payne, Paul Slater, and Dorianne Finlay, our PPI representative, because without them, this project would not be undertaken. There's no me in anything. This is a team event. So I thank you all. But ladies and gentlemen, I just want to grab your attention for one more second. Marie Curie have asked the team now to engage in the development of a roundtable event, which will essentially help to inform the development of a healthcare assistant policy brief. I hope to have the date established, but it will be established by the end of December. And we're going to ask for people to attend. So if you're interested in attending, I would really like to hear your thoughts and your input. There are a number of publications from this project, and I'm happy to share them with the All Ireland if anyone wants to get access to them. But the next stage, folks, of this webinar, we're going to stop recording. It's all about over to you.